Hi everyone, welcome to part 3 of Unit 1, Blood and Cardiovascular Disorders. In this particular lesson we're going to be examining shock and hypertension. We'll start off by defining the etiology, briefly the pathogenesis, and then look at the clinical manifestation of shock, and then we'll move on to hypertension. We probably should have done hypertension when we did the vascular disorders in part 1, but there probably just wasn't space over there, so we'll do it right now. The definition of shock is the inability of the cardiovascular system to maintain adequate end-organ perfusion and consequently the delivery of various nutrients and oxygen to the tissue. In other words, the cardiac output does not match what the tissues demand. We'll go over the clinical manifestations of shock first, and then we'll look at the various etiologies for shock. So in terms of the clinical manifestations for shock, it is defined, as mentioned, by arterial hypotension. Because the cardiac output is insufficient to meet the metabolic demands of the tissues, you end up with tissue hypoperfusion, and that's all due to arterial hypotension. So severe hypotension is shock. Consequently, because the cardiac output has declined and there is systemic arterial hypotension, you're going to anticipate altered neurological functioning because of the reduced perfusion of the brain. For example, there might be altered mentation, anxiety, confusion, all the way to coma and death. The cardiac output to the lungs will also be reduced. Consequently, in terms of end-organ functioning of the lungs, you anticipate that the client would experience dyspnea. There's going to be reduced perfusion of the skin, resulting in cold, mottled, and clammy skin, except as we'll see in distributive or septic shock, where it is kind of the opposite. The extremities are going to feel warm and perfused. Oliguria is also an anticipated clinical manifestation due to the decreased perfusion of the kidneys. And lastly, in terms of one of the key blood tests that can be used to diagnose shock, there should be an increase in serum lactate levels. And that's because there's going to be an increased reliance on anaerobic respirations, since the tissues are not going to be perfused with blood, or there's going to be reduced perfusion of blood and consequently reduced delivery of oxygen, so the tissues have to rely on anaerobic respiration, resulting in an increase in blood lactate levels. Lastly, one of the key compensatory responses, as we know from A&P, to a decrease in blood pressure, systemic blood pressure, is going to be tachycardia. So tachycardia is one of the key clinical manifestations of shock. Let's now look at the various types of shock. Firstly, something that we're probably familiar with, all of us, is hypovolemic, and a subset of that would be hemorrhagic shock. So the etiology of this type of shock would be hemorrhage, where you have actual frank blood loss, trauma also resulting in blood loss, although it might be internal bleeding. Anytime the actual blood volume is decreased, it doesn't actually have to leave your body. If it leaves the vascular system and moves out into the so-called third space, it's still an effective decrease in circulating blood volume, which can result in hypovolemic or hemorrhagic shock. Severe burns does not result in actual hemorrhage, but you do have a decrease in circulating blood volume, because in severe burns there is a massive inflammatory response resulting in a lot of fluid exudation, and ultimately fluid is pushed out of the cardiovascular system into the so-called third spaces, the interstitial spaces. So more and more fluid gets pushed out of the blood vessels, resulting in an effective decrease in circulating blood volume, thereby leading to hypovolemic shock. Similarly, in severe diarrhea, you lose a lot of fluid, which might not be blood or hemorrhagic diarrhea, but it could just simply be profuse, intractable diarrhea, resulting in a lot of fluid loss, and that can lead to hypovolemic shock. Another type of shock is cardiogenic shock, and cardiogenic shock is when the functioning of the heart has declined, whereby the actual cardiac output of the heart has decreased significantly. That could, example, occur post-MI, post various serious arrhythmias, after cardiomyopathy, for example, hypertrophic or dilated cardiomyopathy, and in acute valvular dysfunction. In this case, the heart is just not pumping properly. The ventricles are not contracting properly. Cardiac output is going to decline significantly. And if you remember again from A&P, blood pressure equals to cardiac output times total peripheral resistance. So if cardiac output decreases, blood pressure will automatically decrease. This can result in cardiogenic shock. The third type of shock is distributive or septic shock. In this particular case, there is a systemic bacterial infection resulting in bacteremia, and consequently, all the inflammatory mediators released by the bacterial infection causes systemic vasodilation. Because of this dysregulated systemic immune response, the systemic inflammation triggers this systemic vasodilation, and with all the blood vessels suddenly dilate simultaneously, more or less, that's going to result in systemic hypotension, severe arterial hypotension, or shock. Remember again, blood pressure equals to cardiac output times total peripheral resistance. In the case of cardiogenic shock, blood pressure plummets because of a decline in the cardiac output. But in this particular case, blood pressure plummets not because of a decline in the cardiac output, but because of a decline in total peripheral resistance. Why does total peripheral resistance decrease? That's because of the systemic release of all these vasoactive inflammatory mediators as a consequence of a systemic bacterial infection or bacteremia. The clinical manifestations of all these types of shock are, as we described previously, except in the case of distributives of septic shock, instead of having a cold mottled skin, the nurse would assess skin that is warm and flushed. That's because you have the systemic vasodilation. Normally in other forms of shock, such as hypovolemic or cardiogenic shock, the body needs to divert all the blood flow to the core internal organs. So blood flow to the skin will be reduced. Instead, blood flow to the heart and blood flow to the brain will be tried to be maintained. The body will try to maintain blood flow to those critical key organs. So the skin is going to have a reduced blood flow. The skin is going to appear cold and mottled. It's going to be assessed as cold and mottled. In this particular case for distributed shock, it's kind of the opposite. So that's why it's called distributive shock, because it's really maldistribution of blood. Instead of diverting blood to the core internal organs, now because of the systemic vasodilation, blood flow to the skin, relatively speaking, is increased. Consequently, the nurse would assess warm and flushed extremities. In addition, the other clues that it is septic or distributive shock would be the presence of a fever and leukocytosis. If it's a bacterial infection, you'd see leukocytosis or increased white blood cell count, but you'll also have neutrophilia or an increased neutrophil count, a so-called shift to the left for the neutrophils. Here's a diagram that explains shock. This was from the New England Journal of Medicine. So shock is defined as arterial hypotension, severe arterial hypotension. Consequently, there's going to be signs of tissue hyperperfusion to the brain, resulting in altered mental status, altered mentation, confusion, anxiety, all the way to coma. The skin, as we said, is going to appear mottled and clammy because you want to reduce blood flow to the skin and instead increase or divert as much blood flow to the core internal organs, to the heart, to the brain, even to the kidneys. But blood flow in the cases of severe arterial hypertension, blood flow to the kidneys will also be reduced. Consequently, oliguria is a key clinical manifestation. We already mentioned the presence of elevated blood lactate levels because the body is going to rely more and more on anaerobic respiration. Tachycardia is a compensatory response. So again, if you go back to ANP, blood pressure equals to cardiac output times total peripheral resistance. If blood pressure decreases, say because of septic or distributive shock, that's because resistance, total peripheral resistance has decreased. The only way to compensate for it is to try to increase cardiac output, and cardiac output in turn equals to heart rate times stroke volume. So heart rate is going to increase. So one of the key compensatory responses to shock is tachycardia. So here, this particular diagram shows you the various types of shock. So in terms of the percentages, it might surprise you to know that distributive or septic shock is actually the most common type of shock, about 60%. The other important forms of shock are cardiogenic shock, whereby you have a dysfunction of the actual heart itself, could be due to a myocardial infarction. So a common complication, post-MI complication, is cardiogenic shock. Hypovolemic shock is the other one at 16%. But as you can see, the most common type of shock is not hypovolemic shock, not hemorrhagic shock, is distributive or septic shock typically because of a systemic bacterial infection. We're not going to talk about the other types of shock, would be obstructive shock, and that's typically due to, for example, cardiac tamponade. So we're not going to do that because it's so rare. Please focus on distributive or septic shock, cardiogenic shock, and hypovolemic shock. So once more, just as a summary, for distributive shock, you have systemic vasodilatation, whereby blood flow, instead of being diverted to the core internal organs like to the heart and the brain, instead, because of the systemic vasodilation due to the release of these inflammatory mediators, now blood flow is maldistributed, more towards the skin and less towards the core internal organs over there. For hypovolemic shock, we know it's the loss of either blood in the case of hemorrhage, or plasma in the case of, for example, severe burns or severe diarrhea. You have an effective decrease in circulating blood volume. Cardiogenic shock is because of ventricular failure, so that would be a post-MI complication. Obstructive shock, as I said, don't focus upon it, but if the, let's say, blood volume is fine, so there's no loss of blood or plasma, if the heart is fine, there's no myocardial infarction, but now if you have pericardial tamponade, for example, so you have fluid buildup in the pericardial space, which restricts the contraction of the heart itself. That leads to obstructive shock, whereby the heart literally cannot contract, not because the myocardium is damaged due to an infarct, but because there's no space. There's so much pressure on the outside on the heart due to the fluid buildup in the pericardium. Here's just another table that explains the various types of shock. So cardiogenic shock is because of the failure of the myocardium, the ventricles. The causes of that could be an MI, arrhythmia. Here, cardiac tamponade really should fall under obstructive shock, but anyways. Pulmonary embolism, whereby blood flow through the lungs is also affected. It could be even shut off. That can cause cardiogenic shock. So blood flow through the lungs is reduced, consequently blood flow to the left ventricle is reduced, and as a result, cardiogenic shock develops. For septic or distributive shock, you have a decrease in total peripheral resistance. Why? Because of a systemic bacterial infection, usually gram-negative, or because of other systemic inflammatory conditions such as DIC, disseminated intravascular coagulation. For the case of hypovolemic or hemorrhagic shock, you have inadequate circulating blood volume due to blood loss, severe hemorrhage or severe burns or trauma. I would include severe diarrhea as well. Anaphylactic shock will do when it's a form of actually distributive shock, but anaphylactic shock will do in more detail when we do the immune disorders later on. I think that's unit 3, I believe, or maybe unit 4. And then neurogenic shock will do when we do the neurological disorders over there. In both these cases, you have, in the case of anaphylactic shock, you have, again, a systemic release of various inflammatory mediators over there, especially histamine, and consequently you have massive vasodilation. So very similar to septic or distributive shock. In the case of neurogenic shock, you have inappropriate activation of the sympathetic nervous system. You have dysregulation of the sympathetic nervous system. Again, you have widespread peripheral vasodilation over there, as well as bradycardia. Normally in shock, the compensatory response is tachycardia because of activation of the sympathetic nervous system. Here, the sympathetic nervous system is just completely dysregulated, so you have vasodilation. That's similar to septic or distributive shock, and you also have this, it's very different, bradycardia, whereby because of the dysregulation of the sympathetic nervous system, you can't increase your heart rate, and so the parasympathetic nervous system dominates, consequently bradycardia, which only makes shock worse, because in the case of shock, it's reduced perfusion of the tissues, and now along with bradycardia, that's just going to make it worse. That's why it's called neurogenic shock. We're now going to move on to discuss hypertension, which we probably should have done when we did the vascular disorders, but in either case. So in terms of epidemiology, hypertension is extremely common. 22% of Canadian adults and 52% in the elderly have hypertension. The lifetime risk of developing hypertension in Canadians is approximately 90%, so almost all of us will eventually develop hypertension. And 17% of Canadians are completely unaware that they actually have hypertension. Why is this bad? Because hypertension is the third leading risk factor, modifiable risk factor, that is associated with death. Hypertension is a risk factor for coronary artery disease, heart failure, as we saw, for stroke, as we'll discuss in the neurological disorders, for kidney failure, for peripheral vascular disease that we also discussed. What are the predisposing factors for the development of hypertension? As we mentioned, age, which is non-modifiable, family history, non-modifiable, obesity, alcohol, stress, sedentary lifestyle, smoking, all those are modifiable risk factors. Yes, male sex isn't a modifiable risk factor, but dyslipidemia is. So focus upon the modifiable risk factors, which is everything except for age, family history, and potentially dyslipidemia, although that is related to metabolic syndrome and obesity and a sedentary lifestyle, so it probably is actually modifiable. There are two types of hypertension in terms of the classification. When we say hypertension, we are typically referring to primary hypertension. Primary hypertension is so called because it has an idiopathic cause. We know the risk factors, but we don't really know what exactly causes hypertension, right? There's no one specific cause. It's probably multifactorial. There are probably a dozen different causes, but we don't really know one specific cause, or really even with any degree of certainty, even just two causes, for example. So it's labeled as primary hypertension, in other words, idiopathic. That accounts for the vast majority of cases of hypertension. Consequently, when we say hypertension, unless otherwise specified, we're referring to primary hypertension. Most older adults will develop primary hypertension. There is, however, secondary hypertension. It's called secondary hypertension because there is a known cause, typically because of kidney disease. So we'll discuss that more when we do the urinary disorders, but chronic kidney disease, one of the key clinical manifestations is hypertension, probably because of dysregulation of the renin-angiotensin-aldosterone system. The issue with hypertension is that if it is left untreated, various complications can result, and the main complication is end organ damage. As the blood pressure increases, it will ultimately damage all the organs that it perfuses, which is essentially everything over there. It's going to damage the heart because the heart has to pump against the pressure gradient, so that can lead to increased risk of myocardial infarction. It can cause stresses in the cerebral arteries, leading to an increased risk of stroke. The blood vessel can hemorrhage. We'll look at stroke when we do the neurological disorders. And it can in turn lead to damage to both the glomerulus as well as the vasa recta, the peritubular capillaries that wrap around the kidney tubules, ultimately resulting in chronic kidney disease and end-stage kidney failure. So in other words, the main complication for hypertension is end organ damage. But remember that approximately 20% of Canadians don't even know that they have hypertension. They're unaware that they have hypertension, and yet this end organ damage is occurring silently. Now, please note that the end organ damage doesn't occur in a year or even 5 years or a decade. It takes decades of untreated hypertension in order for the end organ damage to occur, but invariably it will occur. Consequently, hypertension should be assessed, diagnosed, and treated in order to prevent this end organ damage. So talking about end organ damage, you can see over here. So regardless of why hypertension is developed, in most cases, as I said, it's unknown. But now you can result in end organ damage. So what can occur to the heart? The heart itself is going to have to work harder in order to overcome that increased pressure in the systemic circulation. So now you're going to have hypertrophy of the left ventricle. That in turn is, I'm not going to go through all this, but that in turn can lead to eventually to left-sided heart failure. Left-sided heart failure can lead to right-sided heart failure as well. Increased stress upon the heart can eventually lead to ischemic heart disease as atherosclerosis, and which hypertension is a risk factor for atherosclerosis, as we know. That can lead to coronary artery disease. That can lead to increased risk of a myocardial infarction, especially when the plaque ruptures, and that can lead to death as well. Heart failure in turn can lead to death. So this is what we are referring to when we say end organ damage. Hypertension can also damage the arteries just by the mechanical effect over there, as well as increasing the risk of atherosclerosis, which kind of ties into the myocardial infarction. But in the case of the coronary arteries, here you have the relationship over here. It can increase the risk of the plaque rupture and a myocardial infarction and death. And for atherosclerosis, or just even mechanical injury to the aorta, that can lead to various aneurysms. It can lead to a dissecting aortic aneurysm, and if that ruptures, it can lead to death. The cerebral arteries can get damaged, and now you have an increased risk of stroke or a transient ischemic attack. The tiny blood vessels in the retina can get damaged, leading to retinopathy. The tiny blood vessels in the glomerulus, as well as the vasa recta, can get damaged, leading to renal failure. All that can eventually lead to death. So that's what we refer to when we say that if hypertension is left untreated over prolonged periods of time, it can result in end organ damage. So that's it for this very short lesson, fortunately. So please remember, for the pathophysiology, learn the etiology, the modifiable risk factors, very briefly the pathogenesis, but most importantly the clinical manifestations of, in this case, shock and hypertension. Please remember to contact me or your instructor if you have any questions whatsoever and require clarification or assistance with the learning outcomes or the content of the course. Our next lesson is going to be on the respiratory disorders. Thanks everyone. See you then. Bye.